All right. It gives me great pleasure to announce our grand round speaker for this morning, Dr. Jeffrey Kwong, who's one of our PGY4s, who's expressed an interest in going into arthroplasty. I've gotten to know him personally over the last couple of years through regional meetings and most recently at Dallas at the AUKUS meeting. And I wanted to share with y'all a couple of little known facts about Dr. Jeffrey Kwong. So number one, although many know him as a very accomplished cellist, he was this close to being a lead bassist in a garage rock band. Number three, he and Christian McCaffrey were highly recruited to Stanford, and unfortunately, an MCL and ACL injury waylaid his professional and NFL career. So he had to choose medicine. Fortunately, this was a perfect way for him to write his personal statement for orthopedic residencies. Number four, he didn't realize that you could go to a different medical school than your undergraduate. So he continued on at Stanford, but he did get an additional degree in biostats and epidemiology. And he's one of the few people that I've known who's actually been able to use that additional degree. And finally, he's been an exemplar resident since joining our department. He's really leaned into teaching the medical students at UCSF. He's worked with a lot of different faculty on great research. He's been involved in a lot of committees, including the GME, the DEI committee, and he should be lauded for that. Today, he's going to share with us some of his research and his passion on health disparities in orthopedic surgery. And I'd say the final thing that's very impressive to me is he is fluent in both Spanish, Mandarin, and Cantonese. And he said that one of his passions is learning languages. So I'm interested to find out what his next language he'll learn. So without further ado, Dr. Kwong.
All right. Thank you so much for being here today. And thank you so much, Dr. Hansen, for that very kind introduction. Today, I'm very excited to discuss using epidemiology to understand health disparities in orthopedic surgery. So part of this work was supported by a resident and fellows grant, fast track grant from the American Foundation for Surgery of the Hand, and also by a James O. Johnson grant here at UCSF. I have three objectives today. One is to describe how health disparities contribute to differences in access and outcomes for patients with orthopedic condition. Second is to understand how epidemiological methods can be used to answer clinical questions in orthopedic surgery. And third is to propose potential ways to provide better and more equitable care for orthopedic patients. So here's a brief outline of what I will discuss. We'll first start with some background on what are health disparities and why they're important. Then I will discuss a few examples of how epidemiology can be used to understand health disparities within our own healthcare system in both urgent fracture care and elective surgery. And finally, I will conclude with some thoughts on what we can do to address some of these disparities. So starting with some background and with a few definitions. What is health disparity? Well, according to the Centers for Medicare and Medicaid, a health disparity is defined as a preventable difference in the burden of disease, injury, violence, or opportunities to achieve optimal health, health equity, or health outcomes experienced by disadvantaged populations. In my view, the key part of this definition is the part that is preventable. In other words, these differences in health can be fully mitigated as long as they're properly addressed. As we all know, the causes of health disparities are complex and multifactorial. However, some of the most important drivers for health disparities include social determinants of health. And the US Department of Health and Human Services gave the following definition: conditions in the environment where people are born, live, work, play, worship, or age that affect a wide range of health functioning, and quality of life outcomes and risks. Generally, social determinants of health can be broken up into 5 categories. First is education access and quality, and these include items such as health literacy. Second is health access and quality, such as the availability of appointments or geographical distance people have to travel to receive care. Third, neighborhood and built environment, such as the conditions where people live and work that may predispose them to sickness or injury. Fourth, we have social and community contexts, such as immigrating from a foreign country and not speaking English. And lastly is economic stability, such as having the means to pay for healthcare. Insurance type and insurance status would also fall into this category. Ultimately, social determinants of health can lead to health disparities, which in turn lead to inequities in health outcome. Health disparities exist in all aspects of medicine. They're in no way unique to orthopedic surgery. And for example, in this study of patients with non-small cell lung cancer, race, Medicaid coverage, and insurance status were each associated with surgical delays and in turn increased mortality. As well, the availability of various inpatient procedures is not equally distributed. In this study by Bergman and colleagues, essential procedures such as C-sections and heart catheters were pretty widely available, but they found that more complex and relatively newer procedures, such as laparoscopic gastrectomies, showed greater geographical restriction. As a result, it's not hard to imagine that the burden of disease then falls unequally on patients. For example, patients living in more rural areas have a more difficult time dealing with obesity if they need surgical management. But now focusing specifically within our field, health disparities are prevalent and salient. We know that hip fractures should be taken care of expeditiously, and there's a strong demonstrated association of delays in care with mortality. However, race and insurance status have been noted to be significantly related to surgical delays. In this study, using the national inpatient sample from the early 2000s. Not surprisingly, race and insurance status were then also associated with a higher rate of complications. As another example, work coming out of our own department performed by Heather Roberts and Dr. Ward found that access to total hip arthroplasty is not uniform for all patients. White patients and those living in zip codes with higher median income tended to travel longer distances to access total hip arthroplasty care. This suggests they may have greater means to travel further to their hospital of choice, demonstrating a difference in geographical access. Given the prevalence of health disparities in orthopedic surgery and the resulting inequity in care, it's really important to identify and understand the drivers of these disparities so that we can provide better healthcare for all patients. Now, you may say, in this case, this goal of egalitarianism sounds a little idyllic, but I also want to share some more practical reasons why understanding health disparities is important in orthopedic surgery. Reporting of social determinants of health to the Centers for Medicare and Medicaid has actually become mandatory this past year for all inpatients. Whereas in 2023, reporting was completely voluntary, the Centers for Medicare and Medicaid Services has made this reporting a requirement since January 2024, with a submission deadline of May 15th, 2025. In other words, this change is already happening. The Centers for Medicare and Medicaid Services has specifically required reporting on these 5 items: food insecurity, interpersonal safety, housing insecurity, transportation insecurity, and utilities or financial insecurity. They've also required all patients to be screened for social determinants of health, and they also plan to publish the rate of screening positive for these social determinants for each hospital. So clearly, understanding social determinants of health is a focus of the federal government as well. Additionally, social determinants of health recently became very practically important in orthopedic surgery. The Centers for Medicare and Medicaid announced that beginning July 1st, 2024, hospitals must collect information on various social determinants of health and patient-reported outcomes for all patients undergoing inpatient total hip and total knee arthroplasty. These are some of this is the data set that they will require to be collected. And information here includes pre and post-operative patient-reported outcomes, such as who's junior and who's junior, and various social determinants of health, including mental health items from the Promise Global, or VR12, and a health literacy screening tool as well, SLILS2. If collection of a complete data set of these PROs and social determinants of health is less than 50% of all eligible patients undergoing inpatient total hip and total knee arthroplasty, the entire hospital will suffer financially. CMS has said they will withhold 25% of the annual payment update to a hospital. And these hospitals that are delinquent will be disqualified from Medicare value-based purchasing programs. So the annual payment update for hospitals is an automatic yearly increase in payment from CMS.
Hey, sorry about that, Carlos.
To account for rising healthcare costs and inflation from one year to the next. This is typically 2 to 4% of total claims from Medicare. So let's say, for example, a hospital receives $100 million in Medicare fees for fee-for-service claims. They would then have an annual payment update of 4%. If they fail to report the PROs and social determinants of health to CMS, they will then lose 25% of their annual payment update. So for a little bit of math, 25% reduction of 4% is 1%. So this hospital would then lose out in $1 million of revenue from CMS. And I want to emphasize that this penalty would be for the entire hospital system, not just for arthroplasty, not just for orthopedic surgery. Most hospitals have a much bigger value of claims from Medicare than just $100 million per year. So this is a very, very significant financial penalty. To make matters a little more dire, after collecting this data, CMS plans to publicly publish the percentage of patients who achieve substantial clinical benefit after total hip and total knee arthroplasty based on these PRO scores. Though they have not said so yet, the obvious eventual intent is that those hospitals that do not reach the substantial clinical benefit based on PRO scores may be reimbursed less. Given that this information will be publicly available, hospitals that score lower on PROs may also lose out on business. So why are we talking about PROs in a health disparities talk? We know that PRO scores are highly correlated with social determinants of health. As a focus within our own department, Will Rubenstein and Dr. Kuo found that Black and Hispanic race were correlated with less PRO improvement after total hip and total knee arthroplasty at the VA. Consequently, hospitals that treat a more diverse population, such as here in San Francisco, are at real risk of facing significant financial consequences if they do not achieve equity for all patients. Never mind the added difficulty of actually collecting PRO scores and meeting that 50% benchmark. Now, I hope I've established the importance of understanding health disparities in orthopedic surgery. Not only are they important from an equity perspective, but they also have a very real practical and financial implication. Building on this understanding, I want to discuss a few examples of how we've attempted to better understand health disparities, specifically within our own health system, using epidemiological methods. And I'll first start by discussing some work on distal radius fractures. I think one of the most striking parts of our healthcare system that I noticed during my time as a junior resident is that follow-up care for patients with distal radius fractures is strongly dictated by insurance status, insurance type. So imagine you see this patient with a distal radius fracture. If this patient turns out to have healthy SF, they will then follow up at San Francisco General Hospital. If instead they have private insurance, then they can follow up at the OI. I think every resident has sent an email from the general to the OI saying, please schedule this patient for follow-up. But then sometimes they may get a reply back from the practice coordinators saying, sorry, this patient actually has an HMO. So they actually need to go see their PCP for referral before they can actually be scheduled in clinic. Moreover, even patients who are indicated for surgery may not be able to get it right away. Oftentimes, they have to wait for prior authorization before they're able to book surgery. Given the association of earlier surgery with improved outcomes and range of motion in distal radius fractures, we wanted to see if longer wait times due to insurance type may be a driver of inequity in hand surgery. We conducted a retrospective cohort study of patients here at UCSF who had operatively managed distal radius fractures. And we included all patients who were 18 years and older and received surgery between January 2018 to January 2021. We were most interested in urgent but not emergent fractures that were treated on an outpatient basis. So we had some exclusion criteria. This included patients with polytrauma, open fractures, acute carpal tunnel syndrome. And we also excluded patients having revision surgery or surgery for loss of reduction, since that would affect the timing of surgery. We also excluded patients who were having surgery more than 6 weeks out from time of injury, as we consider these patients to be having surgery for correction of a malunion, and thus the surgery was no longer an urgent procedure. So we divided the timeline of care into a few phases to better understand where a possible delay in care was happening. We recorded the time from injury to surgery, and then we further divided this into time from injury to first clinic visit and time from clinic visit to surgery. We categorized patients according to insurance type, and patients were considered to have public insurance if they had Medicare, Medicaid, or insurance obtained through the health insurance marketplaces as established by the Affordable Care Act. Patients were considered to have private insurance if they had standard commercial insurance. A very small minority of patients paid out of pocket or had workers' comp. We then analyzed this data using linear and Cox regression models. And we also performed an a priori power analysis, which indicated we would need at least 65 patients per group to detect a relative hazard of 0.5 at a 5% significance level and 80% power. We also collected information on some covariates, of course, including demographics, and specifically preferred language of care, mechanism of injury, and ASA class. Overall, we gathered 190 patients. To be clear, these were all operatively managed. 131 patients, or 69%, had private insurance, and the majority were female, 129 patients, or about 68% of our cohort. The mean age of these patients was 50.8 years old. And we did find that the time from injury to surgery was significant. Patients with public insurance waited 16 days for surgery compared to 11 days for those with public insurance. And this amounted to a 5.2-day longer wait time in patients with public insurance. A Cox regression model found that patients with public insurance had a hazard ratio of having received surgery of 0.49, indicating that they had approximately half the odds of receiving surgery at any given time period compared to patients with private insurance. In other words, of all operatively treated patients, and again, everyone in this cohort had surgery, a patient with private insurance was twice as likely to have already had surgery than a patient with public insurance at any time point. And you can see this separation on a Kaplan-Meier curve demonstrating that difference. Privately insured patients are here in red, and publicly insured patients here in blue. Breaking this down further, we found that the time from injury to first clinic visit was significantly different between patients with public and private insurance, with publicly insured patients waiting 4.3 days longer on average. However, the time from first clinic visit to surgery was similar between patients and was not statistically significant. So taken together, as you can see on this chart, the majority of the delay occurs in getting the patient to clinic for the first time, not in arranging for surgery. We additionally looked at the relationship between age and time to surgery. Performing a stratified analysis, we found that age acts as an effect modifier on the relationship between time to surgery and insurance. In other words, young versus old age affected time to surgery differently depending on insurance status. Young patients, those less than 65 years old, with public insurance, waited about 1 week longer on average for surgery than did young patients with private insurance. However, in patients older than 65 and who qualify for Medicare, there was no difference in wait times between public and private insurance patients, as the difference was not statistically significant. We finally looked at the relationship between language and time to surgery. In a multivariable analysis, primary language other than English was associated with a 5.4 day longer time to surgery. Because this was a multivariable model, we saw that this effect remained even while insurance type remained significant. Therefore, it's not simply that patients who don't speak English also happen to have poor insurance and therefore wait longer. Rather, this is an independent effect of language on time to surgery. Finally, we looked at mechanism of injury, gender, USA class, and race and ethnicity, and none of these were significant. So these results suggest that insurance as a driver of health disparity in the care of urgent but not emergent fractures such as distal radius fractures, at least within our own UCSF health system. This was due to a longer time to first clinic visit and suggests that patients with public insurance have greater difficulty scheduling with an orthopedic surgeon. And patients with outpatient conditions, such as these, that are urgent but not emergent may be especially vulnerable. There are many steps along the care pathway for insurance-related roadblocks to compound upon one another, from the ED visit to recognize from injury, then to ED visit, then ED visit to clinic visit, then clinic visit to surgery. The effect modification that we found of age on insurance and time to surgery relationship is also especially concerning. According to the American Academy of Orthopaedic Surgeons clinical practice guidelines, generally surgery is recommended for displaced distal radius fractures for any patient younger than 65. By contrast, in those older than 65, there has been no demonstrated benefit in operative versus non-operative management. So the younger patients have the greatest wait times, and yet they are also the ones for whom we would recommend surgery and would benefit the most from operative intervention. Additionally, our findings on the impact on language on time to surgery are consistent with other literature. Rosenberg et al. Found that patients with pediatric ACL tears, a similar orthopedic injury treated with outpatient surgery, in their cohort, they found that primary language other than English was also associated with delays in operative management. So this is not unique to urgent fracture care. It really extends across the spectrum Of course, here at UCSF, we have a ready availability of interpreters, but that's not the case in the vast majority of orthopedic clinics across California. Work from Dr. Sabatini's group in 2019 demonstrated that 80% of a random sample of orthopedic clinics in California requested that Spanish-speaking patients bring a friend or family member to interpret for them. This may lead to delays in care if patients have to coordinate with loved ones to come together for a clinic visit. As well, even though we clearly offer interpretation services, patients may automatically assume the need to bring their own interpreter, given the vast majority of orthopedic clinics require it, even though we do not. Our research also highlights the need that we need to offer interpretation services during appointment scheduling, as the major barrier in getting patients seen in a timely manner is the appointment scheduling portion, not necessarily in getting them scheduled into surgery afterwards. So now that we've seen that for urgent fracture care, health disparities exist on the basis of language and insurance, how about for elective surgeries? To answer this question, we next looked at the case for total hip and total knee arthroplasties. Are there similar barriers to access and outcomes in total joint arthroplasty on the basis of race, insurance, or language? Again, here we used institutional data from UCSF to look at this question. We conducted a retrospective cohort study that included all patients who underwent primary and revision total knee arthroplasty and collected demographic data on these patients. We looked at various outcomes, including complication rate, revision surgery, readmission days, ED visits, and the number of days from office visit to surgery. Overall, in this 8-year period, we had 2,338 total knee arthroplasties and 592 revisions. And you can see in this table, the majority of patients, about 60%, were white in both primary and revision cohort. Most patients did have Medicare insurance, although about 30% of them had commercial insurance. Looking next at this univariate analysis for race, we see that Black patients had the highest rate of complications at 16.9%. And they also had the highest rate of reoperation. At the same time, they had the lowest rate of readmission or ED visits at 3%. And here in the table for revision total knee arthroplasty, we can see that the same held true. These findings suggest that Black patients may have poorer access to or more reluctant to seek postoperative care, since they are not frequently readmitted or seen in the ED. They do have high rates of complications and high rates of reoperation. Looking next at our multivariable regression, for primary TKAs, age and race were associated with greater risks for surgical complications. However, in the revision group, only ASA class was significantly associated with the risk of complications. We then performed a generalized linear model to analyze the number of days from surgery and the relationship between the various demographic factors. We found that here you can see age and insurance were associated with longer times to surgery for primary TKA, whereas for revision, only ASA class was significant. We then broke this down further, and as you can see here, insurance has a huge impact on time to surgery. Patients with Medicare insurance waited on average 193 days from clinic visit to surgery, while those with commercial insurance waited about half that time at 105 days. Meanwhile, self-pay patients, who arguably have the best access of all and don't have to wait for any type of insurance approval, waited only 35 days. And on the other end of the spectrum, you have workers' comp patients who waited more than 200 days between their first clinic visit and primary total knee. Putting this together, we see that race is associated with a higher rate of surgical complications for primary total knee arthroplasty, especially for Black patients. But when it comes to revision total knee, ASA class seemed to be a bigger driver of both complications and time to surgery, suggesting the need for preoperative optimization in the sicker and more complicated cohort. And yes, the type of insurance you have seems to make a big difference in how soon you're able to get a total knee arthroplasty. Lastly, to understand the relationship of language in total joint arthroplasty, we also did a sub-analysis looking at patients within the UCSF cohort, including only Asian American patients who underwent total hip or total knee arthroplasty in 2012 to 2020. This was, again, a retrospective cohort, and we categorized patients as either preferring English or a language other than English as their primary language of communication in the clinical setting. We identified 525 Asian American patients, 168 of whom, 32%, preferred a language other than English. Overall, we found that for primary total hip and total knee arthroplasty, patients with a primary language other than English were at risk for significant health disparities. They resided in zip codes with lower median income, and a greater proportion of these patients had public insurance. In terms of outcomes, they also had longer lengths of stay, but had lower readmission rates and similar rates of complication and revision surgery. This sub-analysis was especially helpful in teasing apart the influence of race from that of language, as this cohort included only Asian American patients, differentiated only by whether or not they preferred English or another language. And while these patients did have greater risk factors, they had similar complications and were not readmitted, especially in light of the fact that non-English speaking patients were generally in the hospital for a longer period of time, perhaps reflecting the influence of language barriers. One has to wonder if they may also be less likely to seek postoperative care, leading to lower rates of readmission. So finally, some concluding thoughts. I hope that through this talk, I've demonstrated that health disparities are important and they have real policy and financial implications for orthopedic surgery, especially considering the CMS mandate to collect and report on health disparities, and the specific focus in collecting social determinants of health in PROs in total joint arthroplasty, which will affect the reimbursement of the entire health system. Epidemiological methods can also be a powerful way to understand health disparities in orthopedic surgery. And finally, even within our own health system, where we pride ourselves in taking care of a diverse patient population and put issues of health equity at the forefront of the UCSF brand, insurance and language continue to have a significant impact on the care of patients. I think most striking is that these issues appear consistent across a range of orthopedic conditions, from both urgent fracture care to elective cases. So what can we do? Based on these findings, I think it's important to offer increased language support, especially in appointment scheduling and on the administrative side. In distal radius fractures, one of the major barriers to care was scheduling clinic visits. And in total joint arthroplasty, we need to make sure that we are adequately capturing the follow-up of our non-English speaking patients, and also making sure that patients with no matter what insurance they come in are able to receive timely care for their arthroplasty. We can hire bilingual staff, and we can also provide more online information in languages other than English. Because again, I want to emphasize that a lot of this disparity appears to happen outside the hospital setting, not necessarily in the direct care of patients. Lastly, I think it's incumbent upon all of us to recognize the most vulnerable patients in our healthcare system, whether on the basis of race, language, insurance, or other factors. recognizing them early and taking extra care to ensure that they are receiving the care that they deserve is something that each and every one of us can contribute. And lastly, I want to end on this graphic that I think many of us have seen before, demonstrating the difference between equality, equity, and justice. In watching a baseball game, in watching a football game, soccer, on the other side of a fence, here in the first scenario on the left, all three people have the same supports, but only the tallest two can see over the fence and watch the game. And the second, with additional support, even the shortest is able to see. But in the third, the systematic barrier is removed. The solid fence is replaced by a wire one. The cause of inequity was addressed. Now everyone is able to fully participate in the joy of watching the game. So I challenge us to consider the ways that we can help our patients remove barriers and provide the best care that we can for all patients that we see. Thank you very much for listening, and special thanks to Dr. Hansen and Dr. Shapiro for guiding me through this research, and to my colleagues who have worked on and started some of these projects before me, including Will, Anthony, Nicole, and the Salad Research. Yeah, thank you, Alicia. So the question was about how we are able to get some of that information, the PROs, who's junior, demographic data, social determinants of health data for SF general patients as required by CMS. I think it'll certainly be challenging, but I think we need to potentially hire staff that for whom this is their dedicated role. As we discussed, part of the issue is that the entire hospital system will be affected. It's not just the Department of Surgery. So I think if the hospital recognizes that there's a lot of money involved, then it may be less expensive to hire someone to specifically get some of these outcome data than to miss that benchmark and then finish. But yeah, maybe hiring someone in particular who's dedicated. I think whether this is good or not, in general, for a fracture that I know is going to be operatively managed, I just say, like, please schedule them ASAP, rather than wait 1 or 2 weeks, because yeah, the biggest barrier is getting them into clinic. And I think our schedulers definitely do a good job of that. The difficulty is especially when when patients have to get a PCP referral first. I think if patient is lucky enough to have a PPO and we can get them scheduled, our schedulers call them the next day, and that's great. But I think there's also a lack of navigators for patients who first need to go see their primary care and then get a referral. And we really lose a lot of patients, at least time-wise, in that regard. Often the PCPs don't understand how long or what is the timeline that we want to fix these fractures, and sometimes they show up later. And yeah, so I guess in my own workflow, to your question, I just try to get them in as soon as possible, and really advocate for them as much as I can. But I'm concerned that some of the biggest roadblocks are getting them lost in the referral system. Yeah, I think that's a tricky question because we certainly don't want to clog up the ED with patients who are waiting for MRIs or CT scans or something like that. But I think there is a role in recognizing that there are some patients who need care but aren't able to get that care on an outpatient basis. There's a lot of patients who, even your example of like an ACL tear or maybe fractures, like elbow fractures that clearly need surgery, but we need a CT scan for operative planning and things like that. I think also to consider is that these patients who are most vulnerable often can't take time off from work, and they're already in the ED. And if we can get them to get a CT or an MRI at the same time, I think would be very valuable for them because they might not be able to take up work to get an additional scan. And part of the whole outpatient workup assumes that patients are able to take the time off from work. And so I would say it's to be used very cautiously, but I think there is a role, especially if there's someone who you recognize needs urgent surgery. Device might get lost in the system.
Thanks so much, Jeffrey. I thought it was really interesting that age was an independent predictor in time to clinic, and that it was inverse of what I thought it would be, that older folks made it quicker. I don't know if you can answer this question, but was there any like looking into that, or are geriatric folks just better plugged into the healthcare system? Interesting.
Yeah, we didn't look at that specifically. I think that is definitely a next step is understanding maybe in a more open-ended way, sort of like with qualitative research, what the specific drivers are. But I think we sort of hypothesize that the issue of age may be because those patients aren't as well plugged in. Patients who have Medicare automatically have better access because at least at UCSF, we accept Medicare insurance and we can see those patients right away. Those patients who might have HMO, even private plans HMO, they may. And then also the issue of often these patients who are younger are working, they're within our workforce, whereas patients who are older, your ED grandma might not be working anymore. Who knows? But then they may be able to have the time to take off to come see us. And so, also considering extending clinic hours, especially for patients who.
Jeffrey, great talk over here. I just want to ask you a question about what is the target that we want to achieve? Because obviously we recognize differences. You talk about maybe like 200 days for Medicare, Medicaid insurance for total joints. How is this number compare with this? Obviously, at UCSF, how does this number compare with like other health system or closed system like Kaiser? How does this system? How do these numbers compare with like different countries in terms of where we are? Because it's good to kind of look at how we're doing, and also what is a goal? What are we trying to achieve in terms of what the right weights should be in terms of distal radius or like elective surgeries?
Yeah, think that's a good question, Dr. Ma. I haven't looked at how we compare to Kaiser or other systems. I think that'd be very interesting. Anecdotally, I know that in socialized medicine countries with socialized medicine, my cousin is a resident in the UK, for example. She tells me that in the UK they wait years for total knee arthroplasty. Similarly, my family being from Hong Kong, I have a relative who's been waiting also long time to get a total knee replacement in Hong Kong. They said, oh, if you survive 5 years with a total knee, you can wait another 5. So I think that is a good question. Like, what is the benchmark that we're trying to reach? I think certainly if we can, it seems like there's a demand for the patients who are self-pay that if they want total knees and they are indicated for it, that they can have it within a month. I think that is certainly, it seems like the demand is there, but certainly compared to other countries, I think we're doing better. I think definitely would have to see if we're doing better compared to other health systems.
Great, but thanks for doing this. I mean, obviously looking at between, within our, health system and UCSF, like how does general look at, versus, UCSF versus like, VA. It'd be nice to kind of get an idea where we stand because, when you put a microscope, on, you will always find differences. The question, how we doing well as a system? The things I actually see it's healthy is that once the patient get in to clinic, within the department, I think, it seems to be we're doing pretty good about getting people into surgery quickly for the fractures, which is just something important because some of the barriers being placed by payers ahead of time in terms of when they could be seen in the system. Once the system seems to wake up, break that down. But thanks for showing us that result.
Thanks, Jeffrey. Remind me, you did not know the rules for American football when you started the residency? Is that correct? That's true, right?
Not completely,
Okay.
but not super familiar.
So I didn't understand the McCaffrey stories, but anyways. So thanks for the talk. It's great, and we're learning lots. I mean, we understand that disparities exist. We kind of get that story. What do we learn about orthopedic patients? I mean, it's natural for us to look at orthopedic conditions when we're doing this type of research, but is there anything unique about orthopedic patients, number one? And number two is that when you are looking at solutions, which I think is really where we're at now. I mean, I don't need to see another paper that says there are differences. I want to know how we fix the differences. Are there any things about orthopedic patients in particular that is going to be different on how we address the problem and try to close those gaps?
I think one of the things that's unique about orthopedics is that we often live in the space of urgent but not emergent. For a lot of our elective cases, they can be done. They don't have to happen right now, but ideally they don't wait 6 months, 1 year, 5 years, things like that. And I think that's a little bit difficult to address, especially with the different payers and things like that, because it's not super urgent in which they we need to keep them in the ER and just do the surgery right now. Of course, there are those, but trying to advocate for our patients, especially who do need surgery and we know they're indicated, but it's not truly elective, or who we recommend to have surgery a little sooner. I think that part is really about patients. Sorry. Yeah, I think emphasizing that that there will be financial penalties. I mean, it's not great to hold a big stick, but Part of it is understanding that the entire health system will be penalized. And I think also recognizing that PROs are important to help us get a better understanding of how we're doing for our patient. I think it's not as good to keep your head in the sand, and ideally we have the PROs so that we can understand how we're doing and our outcomes for our patients, not just because someone is saying, oh, you're not going to get paid if you don't achieve these PROs. But, yeah, I think holding greater outreach to help the other health partners understand why PROs are important, and also there may also be reluctance because it's difficult to capture some of those patients. So offering greater support and also some sort of solutions for how we can get better PROs. iPads are also translated prompts. Sometimes it's difficult because patients are busy, patients don't speak the language, patients for one reason or another, and also making sure that patients understand why this is important too. It's so that we can do better. Thank you very much.